Welcome to the Hand Surgery Podcast on Jersey Finger. This podcast will highlight the important concepts related to the Jersey Finger, or as it is technically called, avulsion of the Flexor digitorum profundus tendon, or for short, the FDP tendon. Imagine this scenario. You are in the thick of a pickup game, maybe football or maybe rugby, adrenaline's pumping. You grab an opponent's jersey, you pull, and then they yank away really hard. And there's this sudden sharp snapping feeling in your finger, maybe a pop. But you think in the heat of the moment, I just jammed or sprained it. But what if that little twinge, that pop, was actually a sign of something way more complex? An injury that if you miss it, could seriously damage how your hand works. So today we're trying to understand the Jersey finger injury. It sounds simple, kind of common, but it's often really misunderstood. In this podcast, we are going to delve into the nuances of the flexor tendon avulsion injury. We'll look at how it happens, why it gets overlooked so easily, the different types which are important, how it's diagnosed, and why getting it treated fast is absolutely critical. Our mission here to help you really appreciate the important details associated with this injury and give you some surprising facts and key insights.
Okay, let's get into it. Because this isn't just another sports injury. There's a really fascinating medical story here about the hand's precision and vulnerability. This is a great starting point, because it really isn't just a minor thing, is it? It's one of those injuries that perfectly shows the delicate balance between the forces our bodies handle and the intricate anatomy meant to deal with these forces. There is a specific way a Jersey finger happens that sets it apart from a simple sprain, and that's why getting the diagnosis correct is so important.
So let's talk mechanics. What's actually going on inside the finger at that moment? Picture it again. The player grabbing the jersey, really holding on tight. Then the opponent pulls away suddenly and forcefully. This action forces the player's finger backwards into extension while it's trying its hardest to flex and hold on. So you've got this huge damaging clash of forces, right? The holding on reflex versus this massive pull.
Exactly. Physiologically speaking, that sudden violent extension rips the FDP tendon off its bone insertion. This tendon is the one that bends the very tip of your finger. It attaches right there at the last bone segment, the distal phalanx, near the distal interphalangeal joint, or DIP joint. Now, something else is really crucial here. The vincula. Think of them like tiny tethers. They give flexible support, but are also critical to the blood supply to the tendon. When the vincula tear during the avulsion, the FDP tendon can snap back much further up the finger or even into the palm, like a rubber band snapping without anything to stop it. This proximal migration of the FDP makes the repair much harder.
Wow. Okay, so ripped clean off. But why does it get mistaken for just a sprain then? Is the pain not that bad initially? Or does the finger still sort of look normal on the outside? Because that's the tricky part, isn't it? How easily it can be missed. It's kind of scary, actually.
That's a really good question, and it's exactly why it's so insidious. Sure, the finger might be swollen, it'll probably hurt, but without knowing specifically what to check for that key functional problem, the inability to actively bend the fingertip well, it might just get blamed on the general pain and swelling. It's not like an obvious broken bone sticking out, The damage is internal in the finger and crucial to the tendon's structure and function.
Okay, that makes sense. So you can't just lump them all together as Jersey finger. There's a whole range, like you said, a roadmap to figure out the exact damage, which brings us to that Leddy and Packer classification system.
Exactly. The Leddy and Packer classification identifies type 1 through 5 and is a treatment roadmap. It helps us sort the injuries based on basically two things. One, how far back up the finger, or how far proximally, the FDP tendon has retracted or pulled back. And two, whether a piece of bone, an avulsion fracture, has came off with the tendon, and if so, how big it is and where it ended up. And this isn't just for textbooks. This classification directly tells us what kind of treatment is needed and how urgent it is. It's fundamental.
And what's really interesting, I read that the ring finger is the most common one affected, by far. Why is that? Is there some anatomical reason?
You're right on that. It's striking, actually. About 75% of cases involve the fourth digit, the ring finger. Now, there's no single absolute proof why, but the leading theory is biomechanical. It seems the ring finger often ends up taking the main force in certain grips. It's usually pretty strong in a power grip, and maybe its position just makes it more likely to get severely pulled into hyperextension when someone pulls away hard, unlike, say, the pinky or thumb, which might slip off more easily. Thus, the ring finger often bears the brunt of the injury.
Okay, that makes sense. So back to the types. Type 2 is the most common.
Yes, type 2 is the type we see most often. In that case, the FDP tendon usually retracts back to the PIP joint. That's the middle joint of the finger, anatomically the proximal interphalangeal joint. And often it's held there by a little chip of bone that got pulled off the distal phalanx. Of course, to retract to the PIP joint, the short vinculum which tethers the FDP tendon at the DIP joint must also tear.
And the other types, what do they look like briefly?
Well, type 1 is more severe in terms of retraction. The tendon goes all the way back into the palm. That means both the long and short vincula have torn, letting it snap back completely. Then you have type 3. That's interesting because there's a large piece of bone that gets pulled off, and that large fragment actually gets stuck near the DIP joint, preventing the tendon from retracting proximally. The large piece of bone acts like an anchor. Types 4 and 5 are more complex combinations involving bone fragments separating from the tendon or associated fractures of the phalanx itself. But the key thing to grasp is how far it retracts and whether the bone is involved drastically changes the urgency and the surgical plan.
That really clears it up. So knowing the type isn't just trivia, it dictates everything. Okay, let's say it happens. How do you spot it? Forget the classifications for a second. What's the absolute number one immediate red flag besides just pain? What should make someone think this might be jersey finger and go see a doctor right away?
The absolute critical sign is the inability to actively flex the DIP joint. You try to bend just the tip of that finger, the very end segment, and nothing. It just won't bend on its own command. It might just sort of hang there nearly straight and limp while your other fingers work fine. You'll also likely have swelling, tenderness, maybe pain around the DIP joint, the PIP joint, or even the knuckle, the MP joint. Further, the history usually follows that classic story, the forceful pull, the tackle, maybe even something like pushing heavy wood if you're a carpenter, and feeling a sudden pop.
Got it. So that inability to bend the tip is key. But even with that, you still may need imaging to know the type right. You can't tell just by looking. How do X-rays and MRIs help confirm it and figure out the specific type?
Yes, imaging is absolutely essential. The clinical exam raises suspicion and can make the diagnosis, but imaging helps confirm and classify this injury. X-ray is usually the first step to look for those bone fragments. We might see a little fleck of bone on the X-ray, maybe sitting near the PIP joint, which tells us it's likely an avulsion fracture along with the tendon rupture. But for the definitive view of the tendon itself, MRI is done. Magnetic resonance imaging is really the gold standard. It shows us the soft tissues incredibly well. We can often see the end of the FDP tendon and see exactly how far it's retracted. Has it gone to the PIP joint, or is it retracted all the way into the palm? Ultrasound can sometimes be helpful too for assessing that tendon recoil, and getting this right is crucial because, we also need to differentiate it from other things. Could it be trigger finger, a swan neck deformity, even a nerve issue like AIN palsy? They can sometimes mimic parts of the jersey finger presentation.
Wow, the detail needed is incredible just to pinpoint the damage. Okay, so you've identified it. Let's say it's confirmed jersey finger. What's next? And crucially, how fast do you need to act? It sounds like time is really of the essence.
You nailed it. What's fascinating and frankly critical, here's the timing. It's paramount for a good outcome. Broadly, you've got two paths. Conservative meaning non-surgical or operative meaning surgery. Now, conservative might be considered but is very rare. Specific cases like someone who presents very late and is completely asymptomatic, which is unusual. But honestly, most patients left untreated end up with ongoing discomfort, swelling, a finger that doesn't move well, and weaker grip. Most people find that unacceptable. So surgery is almost always the preferred route.
Okay, surgery it is for most people, but is it really a ticking clock? What's that window look like for getting the best results?
It absolutely is a race against time. Time is seriously important for type 1 injuries, where the tendon's retracted way back into the palm, and also for type 4, where surgery needs to happen within about 7 to 10 days. That's a really tight window. A major reason is concern about the blood supply to the end of that tendon. It gets compromised quickly when it's detached. For type 2, the most common one, you have a bit more leeway, maybe up to 3 weeks or so. For a good surgical repair, type 2 should ideally be fixed within 2 weeks. These aren't just random deadlines. They're based on biology. The tendon starts to scar, shrink, and retract, making a simple reattachment much harder or impossible the longer you wait.
Except there was one exception, right? Type 3?
Exactly, type 3 is the outlier here. Remember, that's the one with a large bone fragment that anchors the tendon near the DIP joint. Because that fragment stops the tendon from retracting significantly and scarring down badly, you can often successfully fix that fragment, and thus the tendon up to about 3 months after the injury. It really shows why knowing the type is so incredibly important for planning.
Man, just think about that. The difference in outcome just based on how quickly you get accurately diagnosed and treated. It really is a race. But what if someone does miss that window? Say they wait a month, 6 weeks, thinking it'll get better. What happens then?
Yeah, that's where things get much more complicated. If someone comes in after, say, 3 or 4 weeks, maybe longer, then we're talking about late interventions. The challenge is that the FDP tendon and its muscle unit have likely started to shrink and scar down significantly by then. Trying to pull the tendon all the way back down to its original insertion on the bone and reattach it directly becomes incredibly difficult, maybe even impossible without causing problems. Often delaying leads to a chronic fixed flexion contracture. The finger gets stuck in a bent position and can't straighten or flex properly.
So what can you do for those late cases? Are there options, or is it just too late?
There are options, but they're definitely more complex. One main strategy is a 2-stage tendon graft. First stage, we put in a silicone rod called a Hunter rod. This basically creates a smooth tunnel, like a new pathway or sheath for a tendon to glide through. That stays in for a few months. Then, at stage 2, we go back in, take out the rod, and harvest a tendon graft. Often, the graft is the palmaris longus from the forearm if the patient has one. We thread that graft through the tunnel created by the rod, essentially rebuilding the FDP function. It's clever surgery, but it's a long haul compared to an early repair. We had a football player come in 6 months late who needed exactly this surgical reconstruction.
Wow, 2 separate surgeries, months apart.
Yeah. Another option, especially if the joint is unstable or a graft isn't suitable, is to fuse the DIP joint, just make it permanently fused in a slightly bent position, or sometimes a capsulodesis, which is a soft tissue stabilization. This is often combined with removing the scarred stump of the old FDP tendon and maybe doing a flexor digitorum superficialis, FDS tenolysis. That means freeing up this other main flexing tendon, the FDS, from scar tissue to maximize its function. We had a rugby player where just removing the FDP stump and freeing the FDS really improved his finger motion significantly, even without rebuilding the FDP.
Such a stark difference. Early detection really avoids a massive amount of extra surgery and recovery time. So wrapping this part up, what are the typical outcomes? What can someone realistically expect after treatment?
With early appropriate treatment, the results can be quite good, quite satisfactory. Patients often regain good flexion, good movement, and grip strength, can get close to normal. However, it's pretty common to end up with a slight inability to fully straighten the fingertip. Maybe a 10 or 15 degree extension lag at that DIP joint. It might not go perfectly flat. Now, complications, if left untreated, that damaged tendon end can just cause chronic pain and tenderness. With surgery, there are risks too. One is called quadrigia because the FDP tendons to the middle ring and little fingers share a muscle belly. Repairing one too tightly can sometimes limit the movement of the neighboring fingers. Stiffness in the finger is also a risk. And if the volar plate, that's a key ligament on the palm side of the finger joint, gets damaged, you could end up with a flexion contracture where the finger joint gets stuck in a bent position. Finally, with any surgical treatment, there's a small chance of infection.
So even with the early surgery, it's not always perfect.
right? And what's really interesting and maybe a bit humbling for surgeons is that despite all the different ways we've developed to fix these different surgical techniques, including staged tendon grafting, no single technique has consistently shown itself to be definitively superior in clinical outcomes for all cases. This podcast highlights that the Jersey finger is still a complex challenge, but the big takeaways for you, the listener, are these. 1, prompt diagnosis and treatment are absolutely number 1 for a good result. 2, getting the classification right, using the X-ray, maybe MRI, is essential to guide the treatment plan. 3, the treatment has to be tailored to each patient's specific injury. What works for a type 2 might not be right for a type 1 or other types. 4, our understanding keeps evolving. The treatment protocols are always being refined.
That's a fantastic point. Science keeps moving even on established injuries. Okay, so bringing this all together then, what's the final most important message you want to leave everyone with regarding Jersey finger?
It boils down to this. Your hand is an amazing but intricate tool, and that pop or pull you feel during sports injury or even just lifting something heavy could be a sign of a significant injury. If the injury results in a fingertip that suddenly won't bend on its own, don't ignore it. Don't just assume it's a sprain that'll get better. Seek medical attention quickly. Your awareness and your prompt action can genuinely be the difference between a relatively straightforward repair and months, potentially years of complex procedures and hand therapy. Keep in mind, this seemingly simple injury can significantly impact your long-term hand function.
An important reminder about listening to our bodies and the importance of early action. Thank you so much for walking us through that, and thank you all for joining us for this in-depth discussion of Jersey effing jur. Hopefully this gives you a new appreciation for the complexity that can be hidden within a seemingly simple finger injury. We hope you have enjoyed this hand surgery resource podcast on the Jersey finger. For more information, particularly on the different types of avulsion of the FDP or the Jersey finger and their specific management, check out our Hand Surgery Resource app at the Apple Store or at the Google Play Store, or sign on to our website at www.handsurgeryresource.net. Thank you for listening.